Morning, this is Dr. Rutledge, and we're going to talk today about my opinion, which goes against what a lot of bariatric surgeons think. And that's not as critical as some new research, which talks about the microbiome. So we'll be talking about that this morning, and it'll be interesting to see if I can tie it all together for you. So those of you who are patients who are watching, you're going to want to listen because we're going to talk about what your best diet is, and it's not probably what your doctor and your nutritionist are telling you. Although it might be, some people are changing. And so what we'd like to do there is don't listen to this. This is an internet and YouTube video. So maybe your doctor is right and I might be wrong. So listen to your doctor first. The second thing we're going to do is we'll be talking directly to surgeons, and there are a lot of bariatric surgeons now who are adopting my operation, the mini gastric bypass. And I'm happy to say they don't use often or always the name mini gastric bypass. They call it the one anastomosis gastric bypass, and they do it differently, which of course is their right. And one of the things they say is, oh, we have to make the bypass shorter than Dr. Rutledge. And if that's right, then great. I don't think it is, and it demonstrates some confusion, and we'll talk about a couple of those things here later in the talk. So we have a lot to get through, and let's see if I can go all the way from surgery to what you should be eating at dinner tonight. Okay, first of all, we'll do a little introduction. I'm Dr. Rutledge, and I invented the mini gastric bypass now just about 25 years ago in 1997. And at that time, most of the bariatric world, led by American bariatric surgeons, said, oh, this is a bad idea. And I'm happy to say they were wrong. I'm not happy they were wrong, but I'm happy that the mini gastric bypass, in fact, is now one of the most popular operations on earth, and America still hasn't figured that out. But they elected Trump, so who knows? Anyways, when people are doing now what they call the one anastomosis gastric bypass, a lot of discussion has come up about the idea of how long the bypass should be. Now, I've been doing it for 20 some years. I've done it in over 6,000 patients and taught it all around the world. And it's certainly reasonable if other people think they can do it better. And they've made some changes. And so we honor that and respect that. But a lot of the things they say don't make much sense. So one of the things they say is we see patients, maybe 1 or 2 out of every 100 or 1,000, who get really sick, and we call them malnourished, they get liver failure, and they might even die if they're managed by these some surgeons who are not really sure what to do. And what they usually do is they say, oh, it's malnutrition, and we'll feed them. And because if they're not getting enough, because the hypothesis of these surgeons is that it's really simple, the bypass was too long, they can't eat enough, and so they're dying, and we'll just feed them. And they've chosen different ways to feed them, and in some cases, a recent case published this year, the patient dies. And so as a response to these few cases, what has happened is some surgeons say, which seems like common sense, they say, we'll just make the bypass shorter because the bypass interferes with some of the digestion and absorption, particularly of fat and some other vitamins and minerals. So they say, well, we'll fix this problem. We'll just make the bypass shorter. And so we're going to talk a little bit about how that makes no sense. And if it doesn't make much sense, then you might wonder, well, what is the cause of these occasional complications after the MGB, and how can we prevent them? And I'm going to make a case for the fact that it's not by making the bypass shorter. You have to make the correct diagnosis. And the diagnosis that the surgeons who are leading to unfortunate deaths and complications, and to many patients who are suffering from illnesses like bloating, diarrhea, other things like that, are simply not because the bypass is too long. Now, let's just look at this for a second and say, if you think the gut, and this is kind of rough for us to do here without graphs and slides, but if you think roughly that the gut is around 6 meters long, 3 6 is 18, 20 feet long. It's a little longer than that, but for my calculations here. We're going to say, let's say the gut is around 6 meters long. Okay, if it's 6 meters long and Dr. Rutledge bypasses 2 meters, that means there's a remaining 4 meters. Okay, and the MGB has been criticized, say, oh, that bypass is pretty long, could be too long. On the other hand, there's a lot of other surgeons now who are bypassing where they calculate the amount of the bypass by counting backwards from the end. They say, well, we should bypass all of the gut except for the last 2 meters. So that means they have a 4 meter bypass. And not many people are fussing at them, although without a lot of discussion, they have moved their bypass to keeping the last 3 meters, but that still means on average, the vast majority of their patients are getting a 3 meter bypass, which is a meter more or 3 foot more than the MGB. Yet there's a whole bunch of MGB/OAGB/single anastomosis doctors who are saying, oh, no, it should be 150 centimeters. Well, this is a long way of saying is that it's kind of unclear why occasionally people get this problem. And so in short, to keep going on this, so we won't spend the whole discussion on this topic, what a lot of surgeons think is occasionally people get in trouble because the bypass is too long and the residual, what's called common channel, is too short, okay? If that was right, then you might think of other patients who lose a lot of their gut would need to have, 2 or 3 meters or more of their gut. And there's something called short bowel syndrome, and we won't go into that all now, but for those of you who are surgeons, maybe look up and see how much gut you need to live a completely normal life. The other thing is, if you were getting sick because you couldn't eat, then the solution with a short bowel syndrome patient, somebody who's had a loss of their bowel to trauma or other illness, they can be treated by giving them food. In other words, if you're malnourished from short bowel syndrome, which is what they hypothesize the MGB does, they say, oh, the bowel's too short, the functioning gut that hasn't been bypassed too short. So their diagnosis is short bowel syndrome, but we know short bowel syndrome can be fixed. All you do is feed that person intravenously. Yet we have had numerous reports of death following MGB from what has been diagnosed as short bowel syndrome, when the doctors make that diagnosis, which I'm going to argue is a misdiagnosis, and they treat them by feeding them, and they don't get better, and sometimes they die. Now, we're fortunate around the entire earth with the hundreds of thousands of MGBs being done, that's a rare complication, but it's important for the surgeon to know that this rare complication isn't, in my opinion, because of malnutrition. It does result in malnutrition, but if it was malnutrition alone, you could just feed them. And in these reported deaths, the one that's been reported this year that I know of, that person was treated by feeding them. And that patient died. Okay, so seems like, to me, the diagnosis is wrong. So what is going on? Why is it happening? And should we change the length of the bypass limb? Well, I'm going to present 2 patients that just had a sleeve gastrectomy, that is no bypass. So I'm going to say that 3 or 4 times. So the big deal that makes other surgeons say it's very important to shorten the bypass is they say that the bypass causes this complication, okay? The sleeve gastrectomy does not have a bypass, okay? So in theory, they should not have this complication. So I'm going to present to you 2 patients that I've been discussing with their doctors in the United States who had sleeve gastrectomies, husband and wife. They had sleeve gastrectomies several months ago. And their sleeve gastrectomies went great. But again, I'm going to say this a couple of times, they have no bypass. So they can't have short bowel syndrome. They've got all their bowel. There's no bypass. Remember, MGB, the problem, according to many bariatric surgeons, the bypass is too long. So sleeve patients can't have short bowel syndrome because they have, wait for it, all of their bile. So these 2 patients presented to me for consultation with the symptoms exactly the same as these other MGB and duodenal switch and other kinds of patients who get this illness, which is often diagnosed as short bowel syndrome, and then they give them feedings and they're not doing well. In these two patients, the history I'll summarize without all the details is basically they had sleeve gastrectomy around the same time, husband and wife. They went home, and for the first month and a half, 2 months, they did well. Okay. Around the end of the second, beginning of the third month, they started to get nausea, vomiting, bloating, and diarrhea. Various problems. Had trouble eating. Couldn't eat, couldn't eat, couldn't eat. Okay. Began to lose a lot of weight and saw their local doctor, their local ER doctor, the local physicians, numerous times with no real good diagnosis. When I asked specifically to the doctor who's taking care of them, they had trouble coming up with a diagnosis. Most of the blood tests initially were normal. Recently, the husband was unable to walk, was having troubles with his speech, and he was admitted to the hospital, and we're hoping that things can be cleared up on that case. The wife may be getting better, and I'll keep in touch with them, and hopefully we can get them through this, but they don't have a bypass. But they have exactly the same symptoms of the excessive weight loss, malnutrition problems of the reported MGB. But they had a sleeve, no bypass. All right. So to link those two together, I'm going to stop all this discussion and change over to talking about becoming a vegan. All right, calm down. Not exactly. But I want to talk about a wild, powerful, exciting new development. This is something I think earth-shaking. And so what they've done in a recent controlled prospective randomized trial from Canada is they took patients with significant inflammatory bowel disease, and they treated them either with a placebo or they gave them an FMT, which is they had them receive poop, bowel movements from somebody else. Okay, this is called a fecal transplant. Okay, now those of you who have weak stomachs or not a doctor and not familiar with difficult things, you might want to turn this off. But for the past several years, there have been studies based on an Australian surgeon who first did it and got a lot of criticism. I'm familiar. And what he said is that he gave bowel movement contents, poop, to try and be polite. I'll use that hopefully childish word to kind of take the edge off this unpleasant topic. They gave poop, bowel movement contents, to people up their bottom. And that was called a fecal microbiome transplant. They gave the poop from somebody else who presumably was healthy to somebody who was sick. And this began with an infection, a deadly infection that's more common now called Clostridia difficile. And for those who don't know it, if you're a patient, you can Google this, but this is now widely agreed upon. So now surgeons, gastroenterologists, people who bitterly criticized this idea when it was first brought forward are now excited, and almost the entire world has come around to believe that we can fix people with a bacterial infection, with a terrible bacteria, Clostridia difficile. Now they've changed the name a little bit, so I'm using the old name because I'm old. But Clostridia difficile infection, or C. diff, is a terrible and deadly infection with death rates, depending on the situation, up to 50%. And you can save those people's lives by giving them a poop transplant, fecal microbiome transplant. Okay, what's this got to do with the MGB and my poor sleeve patients? Stick around. All right, so what's going on when you give somebody a poop transplant? Well, essentially, you're giving them back the bacteria from a normal person. and they've been screened, but that's a little iffy. But the idea is, if you take somebody dying of C. diff, look it up, dying of a Clostridia difficile infection, and you give them the bowel movement contents from a healthy person, they often get better. So what's that got to do with the MGB? If you don't do this, they can die. In other words, life and death can hang on the bugs, the bacteria, and maybe the viruses and other things that live in your stool, in your bowel movements, in your poop. I'm going to say that a couple more times. Life and death and quality of life can make a difference depending on who's living inside your colon and your small bowel and your stomach, but that's for another day. The bacteria living inside your bowels can make you healthy or sick. And some people with a terrible infection can die with bad bacteria, but can live when given healthy bacteria. One of the most terrible inflammatory diseases ever has just been studied in a controlled prospective trial, and those patients who were treated compared to those who weren't had a high rate of resolution of terrible inflammatory bowel disease when they were given healthy bacteria from some other person's bowel movement. Because the bacteria in us make us who we are. The bacteria inside of us make us who we are. It may be associated with as many illnesses as sadness, depression, psychosis, schizophrenia, heart disease, stroke, dementia. Everything potentially can be related. Well, not everything. That's a little bit much. Many things now are being shown to be related to the bacteria in your gut. And in these amazing situations, they go and get poop and either give it to you as a pill, gross, or up your rear end, grosser, and you can be saved from these terrible diseases. All right, let's take a second, take a breath. In other words, health, life, and death are related to gut bacteria. It's a little bit much to explain here, but one of the ways that the gut bacteria changes your life and your health, life or death, is related to what those bacteria do. One of the most valuable things they do is the new healthy bacteria create short-chain fatty acids in the colon. And this is a long, complicated thing to describe to you, but in short, it means this, that when the body, when the person, when the human being eats fiber, that is like, say, for example, steel-cut oatmeal, that fiber is undigestible. It's essentially wood or cellulose, and we can't digest that. So when that goes down into our gut, it's essentially undigestible sawdust, wood, cellulose, okay? Until it gets to the bacteria in the healthy gut, and I emphasize healthy. When the healthy gut gets this bacteria, when the healthy bacteria gets to this sawdust, this fiber, some bacteria can eat the fiber. These are called fiber feeders. And those bacteria, when they eat the fiber, they release a waste product called short-chain fatty acids. And the short-chain fatty acids make a variety of changes to the lining of the colon, making it healthy, and they absorb into the bloodstream and change you in many ways, including helping you lose weight. We're not talking about that today, though. But not all bacteria are good bacteria. And now we get to the important part. One way to get good bacteria is you could have a poop transplant. Those of you who are viewers and myself probably don't want to sign up for that. But we can get good bacteria in another way. And I'll begin by saying how to get rid of good bacteria. In other words, the kind of bacteria in your gut, you might not be surprised to find, is related to what you eat. And fiber eating good bacteria don't like meat, dairy, or eggs. If you eat a lot of meat, dairy, and eggs, you will have fewer fiber eating bacteria. On the other hand, if you eat high fiber foods like fresh fruits, vegetables, whole grains, no, not cereal, no, not bread, not whole grain bread, but whole grains or beans, you get lots of fiber. In addition, you get very few calories, and people who eat, I would call a healthy diet. A healthy diet is whole grains, oatmeal. Nope, not instant oatmeal. No, not Quaker oats, but steel cut oats. Whole grains, fresh fruit, vegetables, beans, nuts, things like that. They get lots of the good bacteria. So the new research shows if you get good bacteria in your colon via a poop transplant, fecal microbiome transplant, you can potentially resolve, improve, and occasionally cure severe inflammatory bowel disease. Or you could eat oatmeal. Now, let's go back to the mini gastric bypass and my sleeve patients. The sleeve patients were sick, not because they had too long a bypass, but because they had been on a very odd, unusual, doctor-prescribed, goofy diet, which did not include, for example, whole grains, fresh fruits and vegetables, and beans. And they got so sick, one is in the hospital now, may lose significant brain function, his ability to walk, and maybe his life. Why? Not very much in the way of intake of whole grains, fresh fruits, vegetables, nuts, beans. Or the patient could have a poop transplant. Now back to the MGB. Those patients are not sick because they have too long a bypass. They have a bypass. They have a functioning gut that's much longer than biliopancreatic diversion and SASIs and SADIs. They have a much longer small intestine functioning than many other weight loss surgeries. The difference is that they have a different gut bacteria, and it does not respond to intravenous feedings. The diagnosis is not short bowel syndrome. The diagnosis is small intestinal bacterial overgrowth or actual gut bacteria infection in the colon. So, in summary, let's eat healthy out there.